In the pre-hospital setting, the thermal blanket is primarily used to treat hypothermia or any patients that require warming or are unable to maintain their body temperature. The blanket acts as an insulative barrier that aids in reduction of heat loss by preventing heat generated from the patient escaping to the atmosphere, as well as simultaneously radiating heat back to the body. To complete this skill, ensure that any wet clothes are removed from the patient and that they are dried with towels or blankets. Remove the emergency thermal blanket from the plastic bag and ensure to explain the procedure to the patient to ensure they understand and are reassured. Unfold the blanket completely and wrap the blanket around the patient, ensuring to cover the entire body except the head. Ensure to tuck the edges in to avoid any exposure to the atmosphere. Additional blankets can be utilised if needed.
An arterial tourniquet is indicated for the patient who has a significant limb injury or amputation, where there is a life-threatening hemorrhage that cannot be controlled by other external hemorrhage control techniques. Confirm that it is necessary to apply an arterial tourniquet by recognising that the hemorrhage is life-threatening. Explain to the patient that the hemorrhage from their limb is life-threatening and that to control the bleeding, an arterial tourniquet must be applied. Expose the patient's limb as necessary. Always ask for permission from the patient before doing so. Remove the arterial tourniquet from any packaging and ensure the strap, clip, windlass and locking buckle are intact. Position the strap 5 cm proximal to the injury. Pass the strap of the arterial tourniquet under the limb so that it is applied circumferential. Fasten the buckle by clicking it into place. Secure the tourniquet by pulling the tail of the strap firmly. Ensure the tourniquet is applied tightly and that there is no slack. Rotate the windlass to tighten until the hemorrhage is controlled. Secure the windlass into the triangular locking buckle and record the time of application on the strap label.
Go.
Okay, Matt, I'm just going to quickly check for a capillary refill. To do this, I'm going to squeeze your finger for 3 to 5 seconds and then release and then see how long it takes for the blood to flow again. Now I'm going to perform a central cap refill. To do this, I'm going to remove the clothing that's in the way of the sternum, and I'm going to use my finger and press for 3 to 5 seconds and count how long it takes for the blood to go back.
The inline extrication should be performed for patients who have a suspected spinal injury and are not time critical. Before beginning an inline extrication, ensure that you are wearing the appropriate PPE. These include gloves, goggles, and you should also wear a high visibility vest or jacket and safety helmet. Ensure that MFS or CFS crew remove the roof to facilitate the inline extrication, and whilst this is being completed, you should communicate with the patient so they are aware of what is going on. One of the paramedic team members should be staying with the patient at all times to explain the process of the extrication.
I'm allowed to unload the ambulance. Because you're not time critical, we'll be applying some structures to your back and your neck to keep your spine in place, and then we'll be removing you through the back of the car. Is that okay?
Remind the patient of the importance of staying still and refraining from moving their head. And at this point, apply a manual C-spine immobilization from behind the patient's head and use a C-collar to help maintain the C-spine.
Yes, now that the collar is on, we'll be tilting the seat back, placing in an organ to help keep the spine still, and then putting it back in. I'll help support you while we're doing that. Is that okay?
Prepare the organ spine splint 2 and then perform manual C-spine immobilization from the front of the patient. Lay the patient's seat back if able to, otherwise lean them forward slightly. Apply the organ spine splint 2 according to the organ spine splint 2 information sheet.
Okay, Jess, we'll be lowering the seat again and I'll help support you while we're doing so. We'll apply some lifting straps and a spinal board and then lower you to the spinal board and support you in the movement out to the stretcher. Is that okay?
2 weight-bearing belts should be applied to the external handles on the back of the organ spine splint 2. In this way, the patient can be extricated from their position in the confined space or vehicle whilst maintaining spinal alignment. Whilst the patient is being supported in an erect sitting position, One end of the spinal board should be placed at the base of the patient's lower back. The spinal board should rest on the reclined vehicle seat to create a bridge.
Once the spinal board is behind the patient's lower back, we'll then recline the patient backwards on the spinal board slowly while supporting the patient's head and spine. Thereafter, a designated paramedic will align the stretcher with the spinal board, ensuring the stretcher is resting hard up against the rear bumper of the vehicle. Once completed, the stretcher brakes must be applied.
Jess will just be pulling you up the spinal board into the rear of the car. You might feel a bit of pulling, but then we'll get you out. Is that okay?
Foremost, communication is pivotal between all clinicians sliding the patient up the spinal board. Two clinicians will remain alongside the patient either inside or to the side of the vehicle whilst holding the organ splint straps on the side. The two clinicians alongside the patient will now slide the patient up the spinal board simultaneously with the other two clinicians at the rear of the vehicle, pulling the patient up the spinal board with the weight-bearing straps. All four clinicians will continue the slide until the patient's head is at the top of the spinal board. Thereafter, all the clinicians will then slowly and carefully tilt the spinal board upwards so the patient is now parallel with the stretcher.
There's just the final push to the stretcher.
The final stage of the slide will involve a lead clinician who will communicate with the other clinicians as they slide the spinal board with the patient simultaneously across the back seat to the rear of the vehicle and then onto the stretcher, in sync and carefully.
On the count of three, we're going to pull the patient onto the stretcher halfway. We'll stop, reassess, and then pull the patient further onto the stretcher.
Yeah.
Okay, on the count of three, when you guys are ready, 1, 2, 3, go. So, alright, reassess. Patient's partially on the stretcher. And on the count of three again, when you guys are ready, 1, 2, 3, lift. Great, alright, cool, we're almost there. Reassess again, then on count of three, we'll try and get a head right to the head of the stretcher, okay? You guys ready? Count of three. 1, 2, 3, go. Great.
Jess, we're just going to tilt you to one side to remove the spinal board, and then we'll lay you back down.
Once a patient is on the stretcher, a log roll will be performed, removing the spinal board from underneath the patient.
On count of three, we're going to roll the patient to the patient's left side, and we're going to remove the spinal board from the patient's right side. So when you guys are ready, on the count of three. 1, 2, 3. And 1, 2, 3, roll back.
Since the vacuum mattress or vac mat will not be used, the organ spinal splint 2 does not need to be removed. The patient will be transported to the hospital within the device.